When this appears on the skin of an elderly person, it is a sign of death. Hello, I am Dr. C, and welcome back to the Integrated Health Channel. We need to talk about one of the most terrifying fears that haunts families caring for an elderly loved one, especially those facing serious chronic illness. It is a fear rooted in misinformation, intense love, and profound helplessness. The fear that you might miss the one final undeniable signal. The title of today's discussion is direct, and perhaps a little alarming, but we must address it. When this appears on the skin of an elderly person, it is a sign of death. I know why you clicked on this video. You are searching for clarity in a moment of extreme uncertainty. You are looking at a patch of skin, maybe on a grandparent's leg, on your parents' hands. Or maybe you are an older adult looking at your own body, and you are seeing colors and patterns that were not there yesterday. Immediately, your mind jumps to the worst possible conclusion. The specific skin sign that generates this immense, paralyzing fear is what we, in geriatrics, often refer to as skin mottling or livedo reticularis. It is typically described as a purplish or reddish-blue lacy net-like pattern, usually appearing first on the extremities, the feet, the legs, and eventually moving up. In many ways, it is the body's visual warning sign that blood circulation is severely failing. I want to share a story with you, a very common scenario that illustrates the power of this fear. Let's call her Mrs. Helen. Mrs. Helen was 92 years old, living comfortably at home with her daughter Sarah, providing dedicated care. Mrs. Helen had advanced dementia. She was frail, but she was relatively stable. Her daily routine was predictable, her appetite fair, and her pain managed. Sarah was exhausted, but felt like she had a handle on the situation. One chilly evening, as Sarah was helping Mrs. Helen change into her pajamas, she saw it. On the pale, thin skin of her mother's lower legs and feet, there was this disturbing marbling pattern. It was cold to the touch, and it was distinctly blue and purple, arranged in a spiderweb design. Sarah immediately went cold with panic. She had read about this change online. She knew the phrase. She had seen the articles that described this mottled appearance as the body shutting down, often occurring hours or perhaps a day or two before death. In that instant, Sarah didn't see a manageable symptom. She saw a countdown clock. She spent the entire night paralyzed, convinced her mother was actively dying, panicking that she had somehow failed to provide comfort in these final hours. When I received Sarah's frantic call the next morning, her voice was shaking. She wasn't asking about pain or breathing. She was only asking about the color. She felt a crushing guilt that she had overlooked a critical sign that would have allowed her to prepare emotionally and perhaps call the rest of the family sooner. This feeling of missing the moment, of misinterpreting the body's quiet language, is a universal caregiver agony. If you are experiencing this anxiety right now, I want you to take a deep breath. Your fear is valid. Your concern is deeply human. The skin does tell a profound story about internal health. But that story is not always an immediate, simple declaration of the end. This is the critical differentiation we need to make today. Distinguishing between the serious, life-limiting signs of true circulatory failure and the benign, though often alarming, dermatological changes that simply accompany advanced age, poor hydration, or pressure. When you see a change in skin color or texture, it can feel like a sudden, catastrophic shift. But the reality of aging skin is that it is thinner, more delicate, and far less resilient. It bruises more easily, heals slower, and reflects changes in blood pressure and core temperature much more vividly than young skin. We need to stop treating every bruise, every red patch, every area of dryness as an immediate death sentence, because that kind of panic inhibits good care. However, we cannot ignore the true, serious implication of certain patterns. When mottling is a sign of imminent death, it is not an isolated event. It is one piece of a much larger observable picture of organ system failure. It tells us that the heart and the vascular system are prioritizing blood flow to the core organs, the brain, the heart, the lungs, at the expense of the peripheral tissues like the skin on the legs and arms. Throughout this discussion, I promise to be clear, precise, and direct. We are going to break down the differences. We will identify the 4 key skin changes that cause the most confusion and discuss what they truly mean in the context of advanced age: mottling, senile purpura, pressure ulcers, and cyanosis. Our goal is not to eliminate your concern, but to transform your fear into informed action. We want to replace panic with preparation and uncertainty with comfort. By the end of this, you will know exactly when a skin change requires immediate emergency intervention, when it simply requires better comfort care, and when it is merely the normal, often disconcerting, consequence of a long life. Let's begin by defining the context. What makes the skin of an elderly person so vulnerable to telling these internal stories? The vulnerability of the skin in late life is fascinating, yet often frightening for families. It is the largest organ, and frankly, the least supported by reserves when the core systems of the body begin to fail. To understand why certain skin changes are normal aging and why others signal impending crisis, we must first look deep into the structure itself. The skin is not just a uniform sheet. It is a three-layered security system: the epidermis, the dermis, and the subcutaneous fat. As we age, every single one of these layers undergoes significant structural compromise. The epidermis, the thin outermost layer, serves as our primary physical and microbial barrier. In old age, the cell turnover rate slows dramatically. This means wounds take longer to heal, and the skin becomes less effective at repelling infections. Hence, the increased frequency of issues like persistent fungal infections or slow-to-resolve rashes in the elderly. Furthermore, the junction between the epidermis and the layer beneath it, called the basement membrane, flattens out. Think of it like a Velcro strip losing its hooks. The layers lose their firm anchor, making the skin incredibly susceptible to shear forces and tears, often resulting in agonizing skin tears even from minor friction. Moving deeper, we encounter the dermis. This is the structural foundation rich in collagen, which provides firmness, and elastin, which provides elasticity and snapback. With the passage of decades, the fibroblasts, the cells responsible for manufacturing fresh collagen and elastin, slow their production dramatically. Moreover, the existing fibers break down due to accumulated sun damage, gravity, and oxidative stress. This loss of structural integrity is why the skin sags and wrinkles, but medically, it's far more serious than cosmetic change. It means the skin has lost its padding and its resilience. It becomes like an old, overstretched rubber band that no longer retracts properly, leaving tissues fragile and prone to permanent indentation. These superficial changes, thinning, dryness, and structural collapse, are only part of the story. The skin is uniquely exposed to the failures of the core body systems, and that is where the distinction between normal aging and a terminal event becomes critical. Consider the vascular system. Poor circulation is endemic in late life, often due to atherosclerosis or diabetes. When the heart struggles to pump, or when blood vessels are stiffened and constricted, the furthest tissues, the skin on the feet, legs, and fingertips, are the first to suffer from oxygen deprivation and nutrient scarcity. This inadequate delivery system results in extremely slow wound healing, chronic ulcers, like pressure sores or diabetic foot ulcers, and critically, changes in color reflecting poor oxygenation, which brings us closer to the central symptom we must discuss. The central failure mechanism in geriatrics, however, is not just the individual breakdown of these layers, but the systemic inability to respond to stress. This is where I introduce a concept you may not have heard before. I call it late-stage neuroplasticity, or perhaps more accurately, the loss of adaptive plasticity. In younger life, the body's systems possess remarkable plasticity, the ability to adapt, reroute, and compensate when faced with damage or infection. If you have a severe stomach flu, your body rapidly adjusts fluid retention, blood pressure, and sends immune cells exactly where they are needed. In late life, this adaptive capacity dramatically declines. The signaling system slows, the reserves are depleted, and the body becomes rigid in its processes. It loses its ability to plastify, to stretch its resources, to meet an acute demand. Think of it this way. When a young person cuts their hand, the systemic response is immediate and robust. Blood vessels constrict and then dilate exactly on cue. Massive resources are mobilized to the site. When an 85-year-old with a compromised circulatory system and thinned skin sustains the same injury, the signaling is delayed. The local blood flow is insufficient to carry the necessary healing components, and the system fails to mount a timely or effective defense. This loss of adaptive plasticity is the key to understanding why minor internal stressors, like a small undiagnosed urinary tract infection or even mild dehydration, can precipitate profound, visible changes on the skin of an elderly individual that would be imperceptible in a younger person. The body simply cannot contain the stress internally, and the most vulnerable organ, the skin, becomes the immediate vent for the pressure. This lack of reserve helps us differentiate between the benign consequences of aging and the critical indicators of disease. Normal aging results in predictable, slow-moving changes: generalized dryness, xerosis, harmless cherry angiomas, small red dots, the development of skin tags, and the accumulation of age spots, lentigines. These are the results of a long life lived. While they require management, like moisturizing and sun protection, they are not, in themselves, death sentences. Disease or terminal failure, however, results in sudden, rapid, and widespread systemic changes reflected in the skin because the body has run out of its adaptive reserves. When you see changes like sudden massive edema or jaundice reflecting liver failure or persistent non-healing ulcers that deepen quickly, you are seeing a systemic failure, a loss of that critical plasticity. The most concerning signs, the ones that truly signal an emergency or a terminal decline, are those that reflect a deep circulatory collapse. And these are often dismissed or misinterpreted as simple bruising or coldness. These specific changes are our topic for the next discussion, where we will examine the symptom that causes the most fear in caregivers, the marble-like discoloration that can appear in the final hours, and what it truly signifies about the internal environment. We have just discussed the visible changes that occur in the final phase of life, specifically the marbling or mottling of the skin. This physical manifestation, caused by the body prioritizing circulation to vital organs, is unsettling, but understanding it is the first step toward effective action. When we see this sign, panic is the natural human reaction. But as your physician and guide, I need to be absolutely direct. At this stage, our goal fundamentally shifts. We are no longer aiming for curative measures. Our singular, unwavering focus must be comfort, dignity, and symptom control. This is the geriatric protocol for supportive care. Let's break down the practical, actionable steps you must take to ensure the highest quality of peace during this transition. The immediate comfort protocol. When skin mottling or profound peripheral coldness appears, the caregiver's instinct is often to rush in with aggressive heat. This is the first critical point of knowledge. Do not apply external, high heat sources. The skin is already fragile, and the lack of circulation means the body cannot efficiently distribute or regulate temperature. A heating pad, an electric blanket set too high, or a hot water bottle can cause severe burns extremely quickly without the person even registering the pain because the skin's sensory feedback loop is compromised. Instead, manage the perceived coldness with soft, light blankets, a thin fleece, or a favorite quilt. Focus on insulating gently, allowing natural body warmth to create a pocket of comfort. Positioning and pressure. Poor circulation combined with immobility is a recipe for severe pressure sores, which cause immense pain and infections. If the person is tolerating movement, they must be gently repositioned every 2 hours, or at least minor shifts in position should be facilitated. Use soft pillows or specialized foam wedges to offload pressure from the heels, the tailbone, and the hips. Remember, movement at this stage is not about exercise. It is about prevention and comfort. If repositioning causes distress, stop immediately. Comfort always outweighs compliance. The medical management kit, symptom control. This is where open, honest communication with the hospice team or palliative care physician is paramount. We manage suffering, even if the person cannot verbalize it. 1. Pain control. Pain management is the cornerstone of comfort care. Even if the individual appears unconscious, we must assume they are experiencing some level of discomfort related to their disease process. You should have clear, pre-authorized instructions for PRN, pro-renata, or as needed, medications. Often, these medications are administered sublingually, under the tongue, or buccally, between the cheek and gum, if swallowing is difficult. Liquid morphine, for example, is often used not just for pain, but critically to treat shortness of breath or air hunger. Let me address a common fear directly. When used appropriately under medical supervision, palliative doses of opioids to ease severe breathing difficulty do not hasten death. They alleviate profound suffering. They make the final breaths peaceful, not strained. 2. Managing agitation and anxiety. Anxiety is another form of pain. As the body declines, confusion, restlessness, or agitation, sometimes called terminal restlessness, can occur. We must have medications on hand, such as low-dose anxiolytics, administered through the non-oral routes we discussed, to manage this. The goal is calmness, not sedation into unconsciousness, unless that is necessary to achieve freedom from extreme distress. 3. Oral care. The hydration. Myth? As the end nears, the ability to swallow effectively disappears, and the body's need for fluids diminishes dramatically. Caregivers often equate withholding water with cruelty, but forcing liquids or using intravenous hydration in the final days can cause significant distress, leading to fluid accumulation, congestion, and difficulty breathing. Instead, we focus on meticulous oral care. A dry mouth is painful and uncomfortable. Use soft, moist sponge swabs, and sometimes called toothet sticks, frequently, every 15 to 30 minutes, to keep the lips and tongue damp. Use high-quality lip balm. This is the gentle way to provide relief without introducing unnecessary fluid volume into a body that is already shutting down its processing systems. Adapting the environment, creating a sanctuary. The physical surroundings profoundly affect the final experience, both for the patient and the family. Lighting and sound. The environment should be peaceful. Avoid harsh, bright overhead lights. Use warm, soft, indirect lighting, a bedside lamp, for instance. Hearing is often the last sense to diminish. Keep the noise level low. This means turning off unnecessary alerts, minimizing loud conversations, and perhaps introducing soft, familiar music if the patient enjoyed it. But above all, prioritize silence and your presence. Physical accessibility. The focus should be on the patient's immediate comfort zone. Ensure the bed is positioned so family members can easily access both sides, allowing for touch and closeness. If possible, a hospital bed that can be adjusted facilitates comfort positioning and allows the head to be slightly elevated to ease breathing. Keep essential items, medications, sponges, tissues, readily accessible. the role of physical and emotional presence. This step requires no medication, no special equipment, but it is the most powerful intervention we possess. Communication. Even if the elder is unresponsive, speak to them. Assume they can hear every word. Use a calm, loving, familiar voice. Tell them they are safe, that you're there, and that they are loved. Share memories, read a favorite passage, or simply hold their hand quietly. Your physical presence is a form of powerful therapeutic medicine. The sense of touch is incredibly comforting. Gentle stroking of the arm or forehead, holding the hand. These actions signal security and connection even when verbal communication is gone. The direct instruction on letting go. For the caregiver, one of the hardest acts is providing permission to let go. Often, the dying individual holds on, waiting until they feel the primary caregiver is okay or not watching. It is a profound act of love and courage to whisper, clearly and sincerely, that it is okay for them to rest, that they will be missed, and that their loved ones will be fine. This is a crucial element of the psychological protocol. Moving beyond the myth of death. We started this discussion by addressing a physical sign often seen as the harbinger of death. Yes, mottling is a late sign, but the solution isn't fighting the natural process. The solution is providing exquisite care. My instruction to you is clear. 1. Be prepared. Have your PRN comfort medications ready, fully understanding when and how to administer them. 2. Prioritize comfort. Use light blankets, ensure frequent gentle repositioning, and maintain rigorous oral hygiene. 3. Be present. Create an environment of peace, communicate constantly, and offer the profound comfort of your loving touch. The fear surrounding the end-of-life process dissolves when we replace uncertainty with clear action. We cannot halt the natural conclusion of life, but we can guarantee that the journey is one of peace, respect, and enduring dignity. This is the integral health we strive for until the very last moment. We began this discussion focusing on a common source of intense anxiety. The physical signs, the mottling, the pallor, the cooling of the extremities, that appear on the skin of an elderly person nearing the conclusion of their journey. We established clearly that these are not sudden, terrifying alarms, but predictable physiological shifts. They are the body's way of communicating that it is slowing down, conserving energy for the core systems, and preparing for rest. Understanding this physiological truth is the first critical step in replacing panic with purpose. When we recognize these cues, our focus, and the focus of the medical team, must transition entirely. The goal is no longer about forcing longevity. The goal becomes ensuring absolute, uncompromised comfort and maintaining enduring human dignity. This is the highest medical directive in geriatrics and palliative care. For those of you acting as caregivers, the children, spouses, or close friends, I need to speak directly to the profound weight of guilt that often accompanies these final days. Many believe that if they stop pushing for aggressive, painful treatments, or if they ease off on demanding nutrition, they are somehow failing their loved one. This is medically and emotionally incorrect. Let us be direct. When the body is actively shutting down, the most loving, respectful, and dignified action you can take is to eliminate pain and unnecessary medical interventions. True integral health at the end of life means ensuring total control over pain and symptom burden. Pain is cruel. It serves no purpose in the process of passing. If a person is in pain, we are failing them, regardless of their prognosis. We must be aggressive with comfort medications, even if those medications cause increased drowsiness. It is a necessary trade-off for peace. Consider the common distress surrounding the refusal of food and drink. Families often push hydration via IVs, believing they are starving their loved one. I want to assure you, near the very end, the body's inability to process food and fluids often means that forced hydration leads to discomfort, swelling, fluid in the lungs, restlessness. The natural cessation of hunger and thirst is often a gentle, protective mechanism. Your physical presence, your handheld, your quiet conversation, this is infinitely more nourishing than any artificial means of sustenance. The core principle here is acceptance, channeled through informed action. We must accept the limitations of medicine when the body is tired and redefine success. Success is not measured in one more day of existence tethered to machines, but in the quality, peace, and sacred respect afforded during those final hours. As geriatricians, our deepest commitment is to facilitate a passing characterized by grace. This means protecting the patient from pain, from unnecessary transfers, from intrusive procedures that will not alter the final outcome, but will certainly compromise their comfort. It means ensuring that their environment, whether at home or in a specialized setting, is calm, validating, and centered entirely on their moment-to-moment need for relief. The final chapter of life is not a moment of failure, but a natural, inevitable culmination of human experience. We do not cease to love simply because the body has run its course. In fact, the love and commitment to presence become sharper, more intensely focused. A life concluded in peace, free from avoidable distress, surrounded by those who offer honest communication and steadfast support, is the definition of a dignified passing, a good death. If the knowledge we shared today helped you replace even a single moment of dread with a single moment of clarity, then our mission on integral health is successful. Use this knowledge not to fear the physical signs, but to recognize the precious cues that tell you it is time to simply be present, to hold their hand, and to ensure their peace. If this discussion brought you comfort or helped you formulate a clearer care plan for a loved one, please subscribe to the channel. Share this video widely with any family or caregiver navigating this sensitive journey. These conversations are too vital, too fundamental to human dignity to remain shrouded in fear and uncertainty. Leave your questions below. Let's continue to build this community of informed, compassionate care. Thank you for trusting me with this essential discussion. Until next time, take care and always prioritize integral health all the way until the very last moment.